This afternoon we have information from the Wyoming Department of Health. Thank you. This afternoon we have some information from the Wyoming Department of Health, and welcome, Stefan. We'll be glad to hear from you.
Thank you, Madam. Thank you, Madam Chairman, members of the committee. Stefan Johansson with the Department of Health. Our agenda today is relatively brief, and I know you're all planning to, or some are planning to go take a tour of the Life Resource Center, which our Superintendent Jeremy Forbes and his staff are very excited to host you. I'm very excited for you all to go there and see some of the progress that's been made over the past several months with the reconstruction and new construction of that facility. So we'll try to be quick, answer any questions that you have, but knowing that you need to get over to Lander later this afternoon. So accordingly, our agenda today, we have a brief update on the Community Services Block Grant. This is a federal requirement for the grant that our Public Health Division receives. And so I'll hand it over to Stephanie Pyle, who is our Senior Administrator of the Public Health Division, who will join us remotely and give the committee a brief update on that grant.
Hi, Stephanie. Welcome.
Good afternoon, Chairman Wilson, committee members. Thank you very much. I'm Stephanie Pyle. I'm the Senior Administrator of the Public Health Division with the Wyoming Department of Health. I'm pleased to be before the committee today for our required report that we give every 3 years on the Community Services Block Grant. For those committees members who have been around a long time, you may remember what this block grant is all about, but I'm happy to walk through and give some basics for the new committee members. This grant is funded through the Community Opportunities Accountability and Training and Educational Services Act of 1998. And as a requirement of this grant, we are directed to present to our state legislature once every 3 years. The purpose of the Community Services Block Grant is to support services and activities for individuals with low incomes to help alleviate the causes and conditions of poverty in communities. This funding is available to U.S. states, territories, and federally recognized tribes and tribal organizations. The target populations are individuals and families with low incomes, as well as low-income communities. States receive funds according to a statutory formula, and in turn, states fund a network of local entities with 90% of their CSBG grant award. This grant is 100% federally funded. There is no local match or MOE required. It's administered at the state level by the Wyoming Department of Health Public Health Division, and our fiscal period is October 1st through September 30th of each year. We receive approximately $3.4 million annually, and this year there were CARES Act dollars added to the grant as well. And again, the requirement is that 90% of the funds go directly into Wyoming communities. Persons receiving services must have an income of 125% or less of the federal poverty level, and the federal poverty level was changed to 200% in March of 2020. However, this is due to expire in September of 2021, when the federal poverty level will revert back to 125%. The state distribution of funds is defined through a poverty formula. 5% is used for state level administration. Another 5% is available for training and technical assistance or special projects, such as the CAP 60 data collection system, which was recently stood up. And the remaining 90% is distributed to counties according to poverty ratings based on the low income population, people who are unemployed, people on SNAP, people on Medicaid, people on Power, people applying to DFS for assistance, and people on Social Security. The local funding distributions are made by tripartite boards, and each board must be comprised of 1/3 elected officials, 1/3 low-income community members, 1/3 community leader representatives. All 23 counties in Wyoming have access to this funding, and in 2015, the Northern Arapaho Tribe was awarded their own funding. Shoshone tribal members access assistance through the Fremont County grantee. Administering the funds are 15 tripartite boards, 2 community action agencies, with 4 boards covering multiple counties. I can give you just some types of assistance that occurred from October 1st, 2019 to September 30th of 2020, so you can see how the dollars are put to work. 10,122 individuals were provided emergency access to food. 2,332 individuals received emergency rent or mortgage assistance. 149 individuals received services related to protection from domestic violence. 281 unemployed individuals obtained a job. 7 obtained a GED, and 22 completed post-secondary education and obtained a certificate or diploma. 52 children enrolled in after-school programs. 329 Wyomingites obtained access to reliable transportation. 875 obtained and/or maintained safe and affordable housing, and 5,020 obtained health services. Some further highlights: 10,989 low-income Wyomingites and 6,324 Wyoming families received services. I've got just a couple of stories to highlight some of the successes that are seen through these funds. After a domestic violence incident in one Wyoming county, a single mother received information from local law enforcement about the YWCA Center for Families and Children. After speaking with their staff, she decided for the safety of her 2 children and herself, she was ready to leave the violent situation. With the assistance of CSBG dollars, she was able to find affordable housing and get 5 months of rental assistance to help build a life free from violence. During this time, she was able to work with advocates to create a safety plan and a plan for her future. She worked extremely hard and was able to start her own business. With this foundation, she was able to start on her path of self-sufficiency for her and her family. I'd like to just close by saying that our grantees who receive these funds, we do encourage them to collaborate with other providers in their communities, so we're not having duplicate services, and really so that people can maximize the services that they are receiving. Outcomes can be traced to individuals served through our federally mandated tracking system, and we're able to monitor those outcomes through a system called ROMA, Results-Oriented Management Assessment. And the program is measured against national performance indicators, and all of those are tracked via statewide database and case management system. So with that, I'd like to thank the committee members for your time, and I would be happy to answer any questions.
Questions for Ms. Pyle? Representative Ottman.
Yes, thank you, Madam Chairman. I was just wondering, possibly that report is in this packet, but if not, can we have a copy of that?
Ms. Pyle.
Madam Chairman, Representative Ottman, we'd be happy to provide you a summary of the information I provided, yes?
Thank you, either paper or online, whichever works better. Thank you.
Thank you.
Senator Hutchings.
Thank you, Madam Chair. This is the second time Pepper has usurped me and got the question. I was trying to send her an email. She spoke so quickly. I'd like to get a copy also. Thank
Okay.
you.
I'm sure.
Good job.
Ms. Powell, if you just send it to either me or LSO, and we'll ship it about. Anybody down in this other end? Oh, okay. Thanks very much.
Thank you, Stephanie. And Madam Chairman, members of the committee, we'll move on to our second item, an overview and an update on the data breach that occurred at the Department of Health over the course of the last month and a half. So what I'd like to do is give this committee a summary, kind of an overview of the platform where the breach occurred, which is called GitHub, give you a sense of what our investigation process looked like, and finally what our mitigation efforts have looked like over the past really over the past 2 months. I know some members of this committee had sat in on a call that we updated legislative leadership and a few other legislators on. So this might be somewhat redundant, but wanted to provide the full overview to the committee. On March 10th of this year, our offices were notified that an analyst at our department had accidentally uploaded files that contained protected health information to a third-party platform called GitHub. GitHub is an internet-based software service that's used primarily for code management, code storage, version control, when you're doing more advanced sort of data processing, coding of various data sets, and also collaborating with folks that you work with or others that manage similar types of code. it's some staff were using this in our department to manage versions, like I mentioned, and an update code really used for various public health reporting requirements that we had during the pandemic and otherwise, and also other types of public health management initiatives. Like I mentioned, the upload to the public repository was absolutely inadvertent and accidental. And in fact, when the staff member realized that that had happened, we were notified immediately. Basically, what happened is in this posting, in this long stream of code, an ignore function was not used, which would prevent those actual files with the protected health information from being called, or in this case, uploaded. We did verify, Madam Chairman and members of the committee, that this was isolated to one employee and not any of the other employees or users on the GitHub platform. That we did in our investigation find out there were 7 Department of Health employees that were using that platform in some way and not in a way that would risk exposure. Just the one resulted in this breach. In terms of our investigation results, 54 test result, COVID test result files, 53 COVID-19 test result files were in some form or fashion compromised, and 1 breath alcohol test file was compromised. The fields that were included in these files for the COVID-19 data included name or patient ID, date of birth, address, and test result. For the blood alcohol test file, there were some driver's license numbers that were included in that particular file. In any of these files that were compromised or impermissibly disclosed, there were no social security numbers, no insurance information, health insurance or otherwise, no financial and no banking information included. In terms of the total number of individuals that we determined were affected to some degree, it's approximately at 164,000 individuals that were affected by the breach. And the exposure on public repositories began on January 8th of this year. And we estimate that there were 13 IP addresses that we were able to verify that potentially accessed the files in some form or fashion, but we cannot determine who that was or if these were, web crawlers that comb all websites basically all the time. So that's something that we don't know. And accordingly, per our federal regulations, as well as our own department policies, we assume the worst and we act as if the worst had happened. Madam Chairman, in terms of the mitigation effort, the risk to individuals, just to summarize for the committee and give you a sense of what we have informed the public about and information that we've provided out to the folks who were affected. That highly sensitive data, again, was not involved in this, including socials or bank account numbers, et cetera. What we think some of the risk could be if these files were accessed and accessed maliciously or used maliciously, could be some online targeting. For example, social media accounts where your date of birth might be your password or something similar could be compromised if someone knows your name, where your location or your address, and potentially that type of information. Similarly, phishing scams. This could be a risk for this type of information getting out. And certainly after the breach occurred and after we had begun notifying people, we did get reports that individuals were being called from folks claiming to be the Department of Health, saying because of this breach, we need X, Y, and Z information, which was clearly a fraudulent activity after this breach. And we tried to do our best to put out press releases, put information out in the media, contact all of the individuals affected to make sure that hopefully they knew that we would never call and ask for that type of information, even after an event like this. Madam Chairman, in terms of the changes the department made following our investigation and our notification of this incident, we did cease all use of GitHub. All accounts were deleted. We verified with GitHub that all of the data that we had pulled back that was potentially exposed has been completely deleted and removed from all of the platforms where it was out. I did want to mention that in terms of working with GitHub, I would be remiss if I didn't say they were extremely helpful. Their attorneys and our attorneys were able to communicate. We were able to communicate with their technical staff. And so this was certainly not the fault of that platform. This is a platform that's usually used for public source code sharing, data management that can be very helpful in a lot of these more data intensive projects. And GitHub was extremely helpful getting us to our mitigation efforts and resolutions here. We also updated, Madam Chairman, all of our Department of Health privacy and security policies, including the frequency within which we train department staff on best practices with privacy and security and data management. And so those have been in the last month fully reviewed and updated. There were two WDH Department of Health employees involved. One of those employees no longer works with the department. The other employee has received sanctions, additional training, and progressive disciplinary actions have been taken. I do want to mention this was an accident. And while I won't discuss any personnel related matters publicly or with this committee, it was just an inadvertent mistake. And so I think the steps that we've taken with the staff involved are appropriate. Certainly the department regrets this happened, especially after what we've all been through the last 15 months, but I believe we've taken the appropriate actions. To close, Madam Chairman, our notices began on April 27th. Many of you probably received letters. If you took a COVID-19 test, you probably received a letter from our department. Those notifications were completed on May 7th. We notified the Office of Civil Rights, which is a federal requirement as a covered entity under HIPAA. We purchased and offered identity theft protection for all of the affected individuals. It's up to the individuals to choose if they would like that identity theft protection. And we established a Department of Health run or contracted information line that runs during business hours that can take concerns, information from people and refer them to the right resources like identity theft protection or staff in my office to answer questions. We also worked very well with, and I have to thank our partner agencies like ETS, our AG's office, DCI, ANI, the governor's office. This was obviously an unfortunate incident, but I think the state agencies worked very well to get us to mitigation and resolution. And finally, Madam Chairman, I would just close by saying again, totally unfortunate accident here. And in the spirit of what we've all been through in the last 15 months, our public health lab, our public health division, our epidemiology units, going back to last March, our department really threw a lot at those units, at those staff, and we threw a lot of staff at those units. There was a lot to do, and we, whether it was temp staff, contract staff, all that we had to do, especially at the lab and our public health units, you run the risk of making mistakes. We were all hands on deck. We've all equated it somewhat to wartime, and I think that's part of the reason that you risk some quality measures slipping, and that's certainly what happened here. But I'm happy to answer any questions. Wanted to give the committee a broad overview of what had happened, and answer any questions that you might have.
Thank you. Questions for Mr. Johansson? Well done. I guess you answered it very well. Thank you. We appreciate your summary of this material for us, just to keep us all posted.
Thank you, Madam Chairman. And I will mention, if I may, we do have at the committee's discretion for the aging topic, the department prepared a bit of a refresher of our long-term care projections, as well as some data on bed occupancy. Madam Chairman, I'll leave that to yours and Mr. Co-Chair's discretion on whether you'd like us to present that or not.
Are you planning to be here tomorrow as well?
Madam Chairman, we will be here virtually tomorrow.
Virtually tomorrow. Let's just hold off and see, so that the other aging Wyoming, that's not going to come out right. The other presenters on aging Wyoming, if we have time, then we will hear it today. Otherwise, we might ask you virtually tomorrow. And I see that we have an opportunity for public comment I beat Mr. Brody to the to the reminder. Is there any public comment on the Department of Health's agency update? No? Well, the one I remembered to ask. Okay. Oh, is there somebody? Okay. Who is it?
Mr. Laycock?
Oh, is he? I don't, he's probably not commenting on this. I don't suppose he might be early to aging Wyoming, I think. Mr. Laycock, are you, oh, you're muted still.
You are correct.
Are you here?
Side.
Aging, okay. So then we have no public comment. So public comment is closed on the Department of Health and Aging Wyoming. So Katie, who do we have in mind to be presenting all of these things? Mr. Laycock, is Carolyn Passano on as well, and who else? Okay, well, seeing as Mr. Laycock is lined up, let's hear from him, and then we've got someone here, and what agents? Oh, okay. Okay, I just want to make sure you weren't from a different agency that I had noticed. Okay, let's hear from Mr. Laycock.
Okay, Madam Chairman, thank you for the opportunity. Once again, Tom Laycock from AARP Wyoming. Behind me is Dozer the Bulldog. Some of the beauty of working from the house. Hope to see you guys soon in person. But my name is Tom Laycock. I'm the Associate State Director for State Advocacy and Communications for AARP Wyoming. I want to thank the committee members for taking the time to consider issues around aging in Wyoming, as well as the Department of Health for their reboot of the long-term care study. There's some fantastic data in there. I certainly hope that folks have time to kind of look through it. But I'm here today because as part of the American Rescue Plan, the federal government is offering states a bump in its FMAP beginning April 21st to enhance, expand, or strengthen home and community-based services through March of 2024. So currently the state plans to use that money on transition funding for those who are transitioning out of institutions and homes. We support that use, think that's a great use. There are some other options available to Wyoming in addition to that prescribed spend by the Department of Health, and I thought I'd kind of bring a couple of those up to you before today. 10,000 Americans turn 65 in America every year, or every day. According to government data, someone turning 65 today has a 70% chance of needing long-term care at some point, often for an average of 3 years. So increased spending for home services is a big deal for Wyoming because we know that treating someone with home services instead of sending them to an institution is a big money saver for the state. The good news for you as policymakers is an AARP national survey found more than 3/4 of adults 50 and over want to stay in the home as long as possible. In a Wyoming specific survey, that number jumped to over 80% of folks interested in aging at home, which is the lowest cost option for a state already spending around $100 million a year on long-term care. So at AARP, we've been working with some experts in the field of LTSS to figure out what we can spend that FMAP money on that might make a good difference for the state. So the three things I'll bring up today is ADRC, as well as considering piloting some projects in the world of caregiver support. So the first one I mentioned, recommendation is funding an Aging and Disability Resource Center. I know we've kind of talked about this before, but for the folks that are new on the committee, 49 states have what's called an ADRC. Broadly stated, they're a combination of a website as well as a manned call center, where if you're looking for information on available services in your area, you can go right away. So I actually used, excuse me, an ADRC myself in the last few months for my 92-year-old grandfather in Iowa, who lives independently, but could use a little help, a few services to help him stay in the home. I was able to call the ADRC in Iowa, explain what my grandfather's physical needs were, and I was given some options for service providers in the area, as well as other possible programs he may qualify for. It saved me hours of Googling and phone calls, and it got me to the right person right away. Wyoming used to have an ADRC. Its $200,000 annual appropriation was defunded in 2015 due to concerns, I think, with the group managing the program. I was a little bit new when that was going away. But since ADRC funding has been removed, The Wyoming Center on Aging and the Wyoming Department of Health's Aging Division are trying to maintain a website with some information on it. However, there's no staff trained in counseling options. We feel the CMS guidance on permissible spends for this FMAP increase specifically cites expanding or strengthening ADRCs as a fully qualified spend of these funds. And those funds could be used for eligible startup and operating costs through at least March of 2024, as we're trying to kind of figure out a more permanent funding source. This is something that I think you'll probably hear in time from the Governor's Healthcare Task Force as well. The second item that I was going to bring up is the concept of Wyoming Home Services and an 1115 waiver. So for the last 4 years,
If I can interrupt for 1 second.
Yeah.
I just, before we move on to the next one, has there been any thought or discussion of the feasibility of integrating that Aging Resource Center into, say, the 211 call center so as to not duplicate or, to build on each other's strengths? Any thought of that?
Yeah, that has been working together to some extent. The Department of Health can probably give you a little more detailed list of kind of where that's at, but they have been working together more since the pandemic as sort of that for sort of initial intake area. But I don't know whether they have that trained counselor that can handle the warm handoff at present. But good thought.
Okay.
You're
Yep.
right.
Go ahead then.
Okay. So the other two items that we're talking about, first of all, is Wyoming Home Services and an 1115 waivers. So for the last 4 years, AARP Wyoming has lobbied to maintain funding for Wyoming Home Services. And it's been an easy target for budget cuts because it is 100% general funded. We do think that there's a case to be made for CMS to allow AARP funding to use to shore up or outright fund Wyoming Home Services program. Because once again, you're trying to, they were talking about using FMAP money to strengthen your existing Medicaid home services program. We think a conversation can be had with CMS that getting to people earlier will actually strengthen the community choices waiver as it exists now. So that's kind of one piece that we're looking at here. However, AARP at Wyoming has also been in discussions with the state of Vermont, which for the last 17 years has offered the Choices for Care program, which offers similar services to Wyoming Home Services using an 1115 waiver demonstration project. In other words, Vermont's found a way to use Medicaid waiver funding to offer home services to those at risk of nursing home placement, but don't yet need a nursing home level of care. So we've been in conversations with those folks, and we've actually got a phone call set up with one of the fellows that actually designed the program in the state of Vermont coming up here in the next month. And for us, I think it seems like a good opportunity for us to kind of get into this, look at how long we want to fund Wyoming Home Services, and then see if it's feasible to offer similar programming in a way that our current providers can, find acceptable and provide some of these same services, maybe using a little more Medicaid funding, which hopefully will create a little more of a long-term state budget savings without a whole lot of upfront costs. So the final thing that I was going to bring up is the certified home program of the state of Idaho. And so this is one of those programs where AARP funds can be used to start up a pilot project to take some of the cost burden for long-term care off the state. So in the Idaho Certified Family Home Program, this program actually reimburses caregivers $1,500 each month for taking care of Medicaid eligible residents at home who would otherwise be serviced by nursing homes. So the application process in Idaho involves a medical and behavioral assessment to make sure the resident is a good fit for the program. In other words, you don't want to put someone into their family caregiver home when it's just not appropriate, when they do need that nursing home level of care. We talked with Idaho's Department of Health and Human Services, and they believe that the program is a big cost savings to the state. They estimate their per member per month cost of sending someone to a nursing home at $5,500 to the Medicaid program, whereas they're spending $1,500 per month to stipend caregivers. That money is actually put together and offered in a manner to use to be able to buy down services, so buy in home services when possible. So the program has greatly reduced the state's Medicaid share of costs over nursing home placement and uses no general fund money to administer the program. Those administrative costs are actually borne by the providers through licensure fees. So they'll pay for the program's administration. And they've also noticed that fraud levels are equal to or actually a little bit less than their other Medicaid programs, according to our conversation with state officials. So it's something that we think may be at least worth piloting, worth looking into. Opening that program could be a mutual benefit to the state's general fund and seniors. You know, we know folks want to be at home. We know that putting folks at home is actually a lower cost option. It's where people want to be in the first place. So we do know AARP funding can absolutely cover most of the startup costs involved in developing and piloting something like this. And we think it's worth a longer conversation. So because we understand the funding is finite, we listed just a few items that we think AARP funding could be used for. There's several other concepts that could fit within that CMS guidelines as well, including workforce training for workers who are interested in healthcare and direct support. So all that said, I know you guys were running a little bit behind. I'll thank you for your time and stand for any questions.
Okay, committee. I can tell Mr. Laycock was cognizant of time because he talked really fast. Any questions for Mr. Laycock? Representative Connolly.
Thank you, Madam Chair, and I'll do my New York and talk really fast as well. I'm just curious, Mr. Laycock, if you are part of in any way either the governor's strike force or dealing or coordinating with Ms. Davis from the governor's office in relation to your suggestion.
Mr.
Madam
Laycock.
Chair, Representative Connolly. Yes, we are on that. We do sit on that healthcare task force.
More questions for Mr. Laycock? Representative Fritttner.
Thank you, Madam Chairman. Mr. Laycock, thank you for the presentation. I wondered if you'd care to introduce your assistant off your right shoulder. It's a silent assistant. It's rather cute.
He is not the slightest bit silent here. He's been snoring the whole time. This is Dozer. Dozer has a few trigger words that we could probably show you. Doze, you gonna tell him what you do?
There his eyes are opening.
Oh yeah. Yeah. It's a hard knock life.
Oh, I love Dozer. Thanks.
Yeah.
Any more questions for Mr. Laycock? And department, I think we'll hold off. Whether we call you back at the end of today or tomorrow, we might ask your thoughts on a few of those things, but okay, thanks very much. Come on down.
Good afternoon, Madam Chairman. My name is Carrie George. I'm representing the Wyoming Healthcare Association. Carolyn was ill, so she asked me to come yesterday at about 1 o'clock, so I'm not quite as prepared, but thank you for listening. I am just speaking a little bit of my experience with skilled nursing facility. We can all speak about the tough year that we had. We all had a tough year, but our skilled nursing really had a tough year. I currently am in charge of skilled nursing facility here in Riverton. We're an 81 bed facility, but I'm at 59 today. We've had a big decrease. Unfortunately, the month of November was when my center contracted the virus. We lost 18 of our residents. Those were 18 long-term care residents and people that they passed. And those were residents that I saw every day, probably more than I saw my family. So not here to really speak about that. We've all had a tough year, like I said, but I wanted to talk a little bit about the expenses that we incur. We're in the last 15 months, it's been pretty rough, but the expenses have gone very wild. A box of gloves that we obviously need. I mean, it's standard precautions, but even more so in that time frame of the 15 months of the COVID virus. They're $25 a box right now. They used to be under $7, right around $7 a box. We're not going to compromise on that, and we certainly didn't. Our rate has stayed the same. Our gloves have gone up amongst, of course, food. We chose to, in my center anyway, feed our staff. They were there long hours, and they put in a great amount of time and care and compassion and things that I can't explain here today in a short period of time. And I know you're behind. The workforce, we're struggling. We're struggling in long-term care. I know holistically across the state, I believe there's 37 of us skilled nursing facilities. There happens to be 3 here in Fremont County. So I'm one of the three. I'm the largest of the three, but not really now because my census is so low. But in that time, we just can't pay our workforce, and it's an honorable career. We did with the Wyoming Board of Nursing, and a big thanks to them and kudos to anyone who helped with that. We were able to get several people in the door to do some basic healthcare and help with ours. Instead of being a CNA and going through that process, they were able to do the emergency care worker. That was huge. It should very much be recognized. They came in the door, and we had 14 of those folks in my center, and 11 stayed as CNAs, and we put them through, and that's huge. Myself, I have a staff of roughly around 90 people right here in Fremont County that work in my center. And that doesn't include our therapy, and it's just a few of our housekeepers. So skilled nursing facilities are in the communities. They're a huge part of the community, and they're not going to go anywhere. And I know Tom spoke earlier. I don't know Tom, and I know that people want to stay in their homes, and I know I'm providing a service that not everybody wants, but they do need. I do have a rehab front, and most of those folks come in and go home. Some are very lucky and have that support. Others don't. And so we're here, and we're not going to go anywhere, and we want to provide these services. And the folks that we care for and the workforce that we have with them are pretty phenomenal. And I just wanted to say, I hope you guys think about that. And it's a real true thing. And it's a huge part of all the communities, and we're needed. And I was very nervous. I stand for any questions.
You did super, Ms. George. Questions for Ms. George? And they'll all be nice questions. Representative Fritttner.
Thank you, Madam Chairman. And Ms. George, thank you for being here and for covering for Carolyn. Tell her we hope she gets better soon.
I certainly hope she does too.
With regard to the issue you related on your increased cost, just specifically toward the glove issue, I'm assuming that's across the board with most of your supplies?
Yes, Madam Chair, yes. I chose to speak with that because A, I'm nervous, and B, it was an easy one to tell a really quick story about. Yes, all of our supplies. When we had our virus, we had lockdown. We came into the center and folks needed to stay in their rooms, and we were in full gear. So full protective PPE, personal protective equipment, of course, food, utilities. We even had to change the temperature because if the doors were closed, we either had to increase or decrease, so utilities were up, as it has been for a lot of things. Food prices. I could go on. We all have even personally seen increases, and that has definitely hit our centers.
So, Madam Chairman, if I may, so early on, that was a breakdown in supply chain and then also an increase in demand. And is that still the case for those costs, or are they gouging you and taking advantage of this moment in time? And is the federal government doing anything to intercede?
Madam Chair, I am paying $25 a box of gloves when I paid $7 before. And that only happened 15 months ago. So in my experience, I would say to you, I haven't seen that go down. I saw it go up, the numbers go up with the supply and demand. We are currently COVID-free. We have been since the end of November. Our county rate is 1.7%. And our expenses are very high. So I don't know officially, but I do know what I am paying. And I would feel like my perspective personally would be, yes, I feel like I'm being gouged.
Representative Connolly.
Thank you, Madam Chair. I'm going to just switch gears just a little bit and forgive my ignorance here about not knowing about the needs of our elderly for long-term care, your obligations to take people or not, as well as funding. And so Medicaid funding or private care funding. Could you kind of give us a really quick primer on that?
Madam Chair, we screen all of our residents that come in. Okay, I hope I'm going to be quick and to the point. So we screen all of our residents and come in. We never turn anyone down. We do two parts to it. We do, for my center in particular, we do a clinical review. Do they meet criteria? Again, a lot of people want to go home and we would love to support that too. That is our goal if it's their goal. Okay. And then the second part, of course, is financial. Do they have Medicaid? Are in my business office in my particular center, and I think the hospital's discharge planners do this as well. If they don't have Medicaid, if it's lapsed for some reason, we will help them with that. We will, we have a checklist and we go about doing that. And so we try to get them on Medicaid so their funding is, so we get paid. And I think I mentioned, but about 78 to 80% of my residents in my center are Medicaid. So at any given moment, and I would fair to guess that that's the typical for most of the skilled nursing facilities. That's a high amount, but it really is a need. I mean, these folks, not everybody has family. So I hope I answered that correctly.
Madam Chair, just to follow up, can I ask how long do people typically live in your center?
Madam Chair, that's tough to answer. We did have a gentleman, unfortunately, that did succumb to COVID in our facility, and he had been there for 14 years. That's not typical. I believe it was Tom that said something about the average length of stay in a long-term care would be roughly 3 years. I could probably get you those numbers, but just off the top of my head, I believe that's pretty accurate. People stay in their homes as long as they can. Usually an event such as a fall or a lot of times we're seeing malnutrition, depression, those things are a piece, and then they come to us. So we have a moment of, getting them healthy and then natural aging process, of course. I hope that answered.
So, Ms. George, the emergency care worker that sounded like was used before you, do you know, was that something that the licensure board put as far as emergency rule that has an expiration? And if it does have an expiration, would it be helpful to have that be a permanent type of personnel?
Madam Chair, I believe that it was an amazing incentive that was put by the board, and I believe it does have an end date. It is the end of this month. According to just a few days ago, I looked on the Wyoming State Board of Nursing website, and they had pushed it back for us, and it was amazing and so helpful, like I stated. And yes, I think it would be great. I think it would be a great introduction to see if they like it. The CNA course is roughly 2.5 to 3 weeks. A CWC offers it, but again, it's still a certain amount of money for someone. This way, we do the background check, they walk in the door, and we do the training for them. And it has been a very powerful experience in my opinion.
I don't suppose we have anyone from the Board of Nursing listening in, do we? By any chance? Because, yeah. Do you have any Wyoming Association of Nursing? Do you know anything about this issue? Not to call on you suddenly when you weren't expecting it, but we're just trying to help Ms. George feel company in
Yes.
being called upon to answer questions, right? I mean, obviously, if it requires statute, we can't fix that by the end of the month, but.
Thank you, Madam Chair. Tony Decklever with the Wyoming Nurses Association. And the Board of Nursing did issue out the emergency healthcare direct care person. and it did have a deadline date on it. I was just getting ready to look it up also myself. What exactly is your question?
Well, the question would be, it sounded like it was very useful in providing them with staff. And so if this were actually something that could usefully provide staff in the future and not just in the past, maybe we would encourage the Board of Nursing to make it a regular thing.
Madam Chair, members of the committee, the challenge for that is that this was an emergency order, but there is federal regulation around nursing assistants. And the federal regulation is that any facility that hires someone to be a nursing assistant must have the certification, go through the entire process of the class and the test and receive their certification within 4 months of employment. So that's in federal law. And so technically, the way that the emergency personnel person was supposed to work is that they were allowed to come into the facilities, but they had to attach themselves to a CNA. Literally, they were not supposed to work unsupervised. They were to be, so they couldn't be, they were not supposed to be given an assignment. You have Hall A, and because you're my emergency person, but my CNA is going to go down Hall B. It was not designed to work that way because they came in off the street with no training. The reason that OBRA in 1987 was put into place was to prevent long-term care facilities from hiring people off the street and just letting them take care of our of Medicare patients, because the care was abysmal. So in 1987, they passed OBRA, which required all CNAs working in long-term care facilities that received Medicare funding to have to go through a state-approved certification process. So, to just say, oh, sure, you can bring anybody in and just throw them on the floor, and at some point you have to get them through the process, violates the federal law. So that would be that challenge.
So it was just allowed, and we're not asking specifics on how they were used, but even if they were used appropriately, where say you have, I mean, if you need to have a 2-person lift or something like that, and you only have one CNA, and then you could have an emergency person, I suppose. That was allowed under emergency, under the COVID emergency. But so back to Ms. George, would if it, what I understand, and obviously we need to investigate further, but that the person has to be appropriately certified within 4 months. But if the training actually is accomplished in less than 3 weeks, it sounds a little, is that what, did I understand that correctly?
Madam Chair, and I agree with what you're saying too. We're very strict on that, where they were, the emergency care worker was with another CNA, but our staff were so exhausted at the time through the virus that it worked wonderful. I would like to say that I believe it got people in the door that wouldn't normally have done that, and it got them income, and it got them into our workforce that we're so desperately needing to have. So what we did is once they came in the door and they were, buddied up with that person, and we would recognize that, we would then send them through our certified nursing assistant class. So I believe that helped us get it through the door. So we have something called a hospitality aid. I'm sure many of the, it's just our play on the words, and I'm sure most of our other centers have that as well. And it's basically a person that can't do any hands-on, kind of the candy striper of days of. So we try to do that, but boy, it just had so many people come in the door. And, we talked about the stimulus checks and all of that, where people were getting, we kept people hired. We consistently had the staff we needed. So I just wanted to mention, I think it's really great. I know workforce is a problem, and I saw something that worked. And so I would love to be able to bridge, understanding the federal, believe me, I know I'm surveyed. And that's important. And we stand on that. And we are taking care of the greatest generation, some amazing people. So we need to have that education. I just felt it got them in the door. So it would be great to sort of bridge that gap.
Katie, would you pencil in for our September meeting to ask the Board of Nursing to come on, so that we might consider possibly, obviously not until the February's, but if there's something that we could do to continue that program, if it needs some kind of licensing board authorization that would still fit within, I don't give you into the whole thing, just put on that, that the Board of Nursing should come in September. Anyway, so Ms. George and Ms. Declever, my idea then would be not to attempt to overcome federal regulation, but if there needs to be some sort of okay from the licensing board to hire staff that would be used legally and appropriately and within the scope of not having any licensure, such that Well, we heard a lot about, workforce training this morning. I don't know if you were here, but for the committee about on-the-job training and that kind of thing. If we could really get something like that where then the people said, hey, I do like this. They get to know the residents, which is often a pleasant part. One of our projects for this aging is to try to figure out anything to help with workforce. So it sounds like there might be some potential there if we can really work all the buttons.
Madam Chair, just a suggestion. The Board of Nursing issues the certificate based on test scores, just like they issue the licenses for registered nurses and LPN for nurses. So it is the Department of Health that regulates the program. And so my suggestion would be to also have, sorry, Stephanie, but to have Laura Hudspeth from the Department of Health, because she is the person that oversees the programming
Oh, good.
of the
Put her on
nursing
the list too,
assistants.
Katie.
Thank you for that.
Warn her stuff.
Yeah.
Okay, excellent ideas. Thank you. Any more questions for Ms. George? Thank you, Tony, for being willing to come down and play rescue aid. Okay, thanks very much. Did you have any more that you wanted to? Joshua. Yeah, that's fine. I was just going to say, committee, one thing, and maybe we'll hear from Josh. We do have on the agenda here requirements for rate rebasing, and maybe I'll just circle back to that after Josh says whatever he wants to say. But hi, Josh. Introduce yourself for the committee if you would.
Madam Chairman, members of the committee, again, Josh Hannes with the Wyoming Hospital Association, and for the purposes of this conversation, also channeling our association president, Eric Boley, and Leading Age Wyoming. I have a few comments. I don't want to repeat anything that was already said. I think we're on the same page with a lot of those other ideas and comments. And I apologize if I jump around a little bit. I can start with the rebasing at a high level, Madam Chairman, if you like. Statutorily, it's supposed to be done. I believe it's every 3 years. I think it's been 7 years since it's been rebased. The average daily cost in a nursing home now is about $275. Medicaid reimbursement, and as you heard before, Medicaid represents a significant proportion of residents in nursing homes. Anyway, that daily reimbursement is about $180 a day. The Department of Health can correct me if I'm off by a little bit, but I think it's in that range. So it's a significant problem that compounds on itself as time goes on, certainly. I would like to talk about just a couple things really quickly. One would be around a comment Representative Connolly made earlier about the governor's task force and looking at sort of visionary ideas for the future. And I think that's an excellent piece of advice. And I think we have an opportunity with ARPA funds to do those. So some of the ideas you've already heard, but using that money to invest in capabilities that we're going to need for the future to deal with an aging population and to address needs that we have today. And you heard some of those. One idea could be could we retrofit, remodel existing facilities so that they can serve multiple purposes. So there are some CMS rules around that. So if you wanted to have independent living and assisted living and long-term and skilled nursing in the same facility, you have to have separate entrances, separate dining rooms, things like that. Obviously, there's a cost to that. But is it worth having a conversation and looking at, is that a meaningful way to move forward and improve our infrastructure for aging services? Relative to workforce, I do want to give some thanks to the governor's office and the Department of Health for a project that we worked on with them between November and March that helped bring in temporary staffing to hospitals, nursing homes, assisted living, hospice. We appreciate their partnership that allowed us to bring in a little over 300 temporary staff, so CNAs and registered nurses into the state during a time of crisis. That was, I think, one of the most important things done with CARES money when we were really in the middle of the pandemic. We had staff at hospitals and nursing homes, permanent staff who, when the help came from this temporary staff, they would cry. They had a lot of people out because they were either COVID positive themselves, they're caring for COVID patients. They had people and staff that were quarantined. They were working long hours. You heard from an administrator here. This was meaningful work that was done and had a real impact. And frankly, I don't know what some of these facilities would have done absent that assistance. But it continues today with staffing shortages. We have a number of nursing homes that are offering pretty significant sign-on bonuses just to have permanent staff come in the door. So, we'd like to continue to have conversations around what could we do with ARPA money, not for temporary staff. I mean, that gets expensive and that's a Band-Aid, but what could we do? What could we hardwire into our system that would be helpful to make sure that we have the staff we need to take care of folks? And I guess I just finish with, a plug for the governor's task force, which could be a place to, and should be a place, I think, to vet a lot of these ideas, to bring forward and have conversations about what are our opportunities to invest in capabilities that we know we're going to need and that we just don't have right now. I think it fits nicely with the infrastructure piece along workforce, physical plant. I think that's an appropriate use of those dollars, and hopefully we can put those to work. But I would stand for any questions.
Questions for Mr. Hannes? Representative Connolly.
Thank you, Madam Chairman. Mr. Hannes, you mentioned the task force again and about the workers. And I've read over not the 1 million pages of our directives, but there is a section that talks about premium pay for workers in essential services like nursing homes and hospitals. And I haven't heard anyone mention that yet. Is that something that's on the agenda?
Mr. Hannes.
Madam Chairman, Representative Connolly, I think it should be, and it was part of the CARES Act funding as well. I think it was specifically referred to as hazard pay, but that was an allowed use of the money. And I think if that's something we need to do now to get permanent staff into these facilities, and it's a tool at our disposal, I think it should be part of the and I should say it has been part of the conversation and should continue to be. And I hope that answers your question.
Madam Chairman, if I may, and this is just more of a comment, I think, and I'm not exactly sure what's the role of this committee when it comes to ARP money, and especially regarding labor health issues. It would seem to me maybe we would have a role. I'm just not sure what it is, and that there's just a lot of ideas being generated about possibilities. And I just hope that we're part of the conversation as we go forward.
Senator Baldwin and I have on occasion been requested to send in lists of ideas about what the informal process has been. But Senator Baldwin, I imagine we might send a little further tweak about pay boosts. More questions? Representative Ottman.
Thank you, Madam Chairman. Just a comment and a question, and I hope it comes over in the spirit in which it's meant. Oftentimes we're looking at problems and we're trying to figure out exactly what to do and how we can fund it and everything. But one thing that I've noticed throughout my experience taking CNA classes and meeting with people and going over to Lander to the facility and down here in Riverton and things like that, is oftentimes people are so busy that the boots on the ground people, the people that are serving the food, the people that are working directly with the residents, the people that are actually the people that we're talking about hazard pay and stuff like that. Sometimes I'm wondering if maybe some input and not threatening, that they're not complaining or whatever, but maybe a way to streamline some events, or maybe how to, some of the difficulties they see, so that possibly something could be done differently, or maybe they could get trained better. But sometimes those things are overlooked, and I'm just offering that as a suggestion. Possibly it's already being done, but I know in certain places, it doesn't matter how much you pay people. If they hate their job, they're not going to stay. So I was just wondering if maybe that level of conversation might be a possibility.
I don't know if that's really a question. I'm not sure Mr. Hannes has an answer for that, but.
Madam Chairman, I'll take a stab at it. Just to be clear, Representative Ottman, are you asking if the boots on the ground, for lack of are being included in conversations about how to address some of these challenges? And I would say yes. I mean, certainly on a facility level. I mean, I would agree that leadership requires talking to people who are dealing directly with patients and closest to the issues. So I'm not going to speak specifically to every facility and how they go about that, but I would say in general, yes.
Okay, I have two questions. One is, and we had this discussion, I think I maybe heard it from Mr. Boley as well, but the issue on enabling facilities to have multiple licenses. So you mentioned it in the sense of using AARP dollars for retrofitting. Is there anything that we can do within the Wyoming licensing statutes to enable the ability of facilities to have multiple licenses other than the need to retrofit for more than one door? Or is there a federal component that is outside of our purview?
Madam Chairman, my understanding is that that is a federal CMS rule and that the state doesn't have influence on that, but I will confirm to make sure that that's correct.
And Katie, we might have, just for the September meeting, I think we were going to have Laura Hudspeth, I think, didn't we mention her? And I'm losing track here this afternoon. There was no coffee for after lunch. I've lost track. That would be, just put a little note so I don't forget. I'm trying to do this because I remember last year we came up with something, we should talk to pharmacy, which is why the pharmacy people are here. And then later we said, why did we say we wanted pharmacy? I know, but to understand that component, because it's been brought up outside of this, but Mr. Hannes knows the idea of being able to get multiple use out of a certain facility, not just the swing bed thing, but adult daycare and that kind of thing. We want to make sure that we understand if there's any role there. And I'll put a star by that AARP dollar part. And then the other question, and actually this might be for Chairman Baldwin and the committee. Actually, I think it's 5 years that we have to rebase, not rather than 3, but could Chairman Baldwin, do we want to ask LSO to draft a rebasing requirement, even though we know that we probably won't have the money to do it, but just on general principles? Or
I think we should, Co-Chair. I think we should do that, and we've got it in our holster if we need it. And if we decide that it's an overburden, then we won't. But let's do it and have it in our holster.
okay, so Mr. Brody, and Katie, if we probably have a standard rebasing bill that we use for various things, if you can.
Madam Chairman, yeah, we won't reinvent the wheel. We'll go back and see what the committee has done in the past.
And sometimes we rebase other things, but they probably all look pretty similar. But I think at least we'll just consider it, I mean, as we used to say playing hockey, the only goal you don't score is the shot you don't take, right? Okay, that's all I had from Mr. Hannes. Any other questions, any final questions for Mr. Hannes? Oh, I had, yes, Senator Furphy.
Thank you, Madam Chair. Well, let me ask about, we've had several discussions about recruiting physicians to our state. Is there anything more that you're aware of that we as a state or you as hospitals can do to support the WWAMI program to encourage more participants in that program and to keep more of the physicians that come out of that program in our state? Do you have any thoughts on that issue?
Mr. Hannes.
Madam Chairman, Senator Furphy, I don't know that I personally have a lot in terms of what more could be done. I do know that there's a current situation where some of the specialties that those students are in are and attempting to come back, there's not jobs in those specialties available. Perhaps something could be done looking at, taking into account the needs of the state, and what specialties are needed where. I'm not intimately involved with the Wyoming program, and I don't know how that would look mechanically. But I do know that that is a current situation where you have students that do want to come back, but the specialty they're in isn't available for them to be employed.
Representative Romero Martinez.
You had mentioned in your comments about wanting to be closer to folks that are basically doing that type of work. And even pre-COVID, the care centers for the elderly seemed already outdated. So I think they might have needed retrofitting for several years. I think along with you and everybody else kind of seen that from, crumbling bricks to just slapping new logos on, buyouts. And then going along with what you were talking about relating to retrofitting, I guess I can't think of any buildings that can be retrofitted just off the top of my head, but the number one thing I'm thinking about in terms of principle for retrofitting is space. You hear these stories about some of these facilities so crammed together that becomes an emergency issue then, which then can somehow be drafted into some type of legislation to maybe qualify for the money to retrofit them. Seems like two different things, but they could be related. You just look at some of the modern school buildings and how they have them broken into pods and how they can almost retrofit within retrofitting. It's built that way, but then it could be almost like a transformer change. I'm not trying to get too sci-fi or anything, but I guess these are just a couple of thoughts, and I'd like to be part of that process. I guess I just wanted to make that comment, and great thoughts. I appreciate you. Thanks.
Sure. Madam Chairman, if I could just respond quickly.
Sure. Mr. Hannes.
Representative Romero Martinez. I agree. One of the other ideas that we presented to this committee and to the governor's task force and others too is opportunities for some of this funding to be used to make nursing homes that are currently semi-private rooms into private rooms as an infection control measure, right? So something else to consider.
Okay, thank you. I feel like we surely must have more. Are there more people on this topic? Because it seems like we have a lot of excess time all of a sudden. Come on down, Marilyn. When does it ever happen that we have to find extra people to comment because we have too much time? Well, let's ask everybody to come back and talk again. We scared them with our talk about overtime. Hi there, introduce yourselves if you please.
Good afternoon. My name is Carmen Rideout. I am the Executive Director of the Hub on Smith, a senior center in Sheridan, Wyoming, and also a member of the Wyoming Association of Senior Project Directors.
Good afternoon, members of the committee. My name is Mary Lynn Schickish, and I'm here today representing the Association of Senior Project Directors, which are essentially the senior centers in the state of Wyoming. What we'd hoped to accomplish today was to introduce the conversation about the role of the community providers for the aging in our state, hoping that through the next couple of meetings, we work with you to build some policy considerations to help build on the existing services in the state. So forgive us if we sound a little too basic. The Hub is perhaps the model senior center program in the state with the greenhouse nursing home activities and everything. So I wanted to have Carmen here with us today, really as kind of a leader. To set the groundwork, I wanted to pull us back to in the mid-70s, and the federal government came up with the whole concept of food programs throughout the country. And they first started with pilot programs that were in community college cafeterias and basements, and Carmen could talk About where did yours start in Sheridan?
The basement of the Salvation Army.
Yes. So basically, the federal legislation grew out of that, creating the congregate meal sites across the country. And what the legislation showed on the federal side was that it was extremely successful in that these meal sites with the congregate gatherings brought seniors together, and the socialization and other things that resulted out of them was very positive. To that end, we provided you real basic stuff. The first sheet is a list of the 40 senior centers in the state of Wyoming. And we just know that many of you have been in your senior centers, and I think the point to bring up here is that they're of all shapes and sizes. As some of them you'll see have received a lot of funding, are very well developed, and others are very small programs. So that's one of the things we wanted to present here. Also, we'll, through our conversation, help you understand and help us understand that the majority of them, actually all of them, are 501c3s. They do receive federal funding through the Division on Aging. Not all of the 23 contracts for the home services, the majority of them were through the senior centers, but 1 or 2 of them were not. And then many of them braid their funding through their counties, their cities, through recreational district grants. And then at the end, I'll talk to you about the senior services, special districts and the senior services healthcare districts that have now been created. What we would envision is hope to grow the community concept for senior services. As you know, they are very much needed in our state. I was relying on my colleagues at the Department of Health who have phenomenal statistics on our aging population. I just did a quick math and over 65 of the latest information about 2019. Over half of our counties have in excess of 25% or 20 to 25% of their aging over the age 65. Several of them have even more significant than that, and that's clearly the direction we're going. So we perceive there's going to be a growing need for services. And then we did the acronyms. We've offered you the acronyms for the ongoing conversations that we're going to have. And then with that, I would be happy to turn it over to Carmen to talk in general about what the programs are and how some of the needs are and what we're doing at these days.
Thank you, Mary Lynn. I have a 2-page sheet here that just summarizes what we do at senior centers across the state. The Wyoming State Plan on Aging in 2017 to 2021 recommends that the primary strategy to manage costs of long-term care is to promote and invest in aging in place through the development of more community-based services. And that's what our senior centers are all about. So I'm a member of the Wyoming Association of Project Directors. We represent the 40 senior centers across the state and in all counties, serving well over 21,000 people. The purpose of our organizations are to keep people at home. A lot of what has already been talked about here today. The year 2020 really demonstrated that places and spaces that senior centers offer have never been more essential in the everyday life of older adults and their families. They're critical parts of the social infrastructure of healthy communities where older adults come to meet, to learn, to share their time and talents, and to link to community resources. Some have compared them to student unions for older people. So each, as Mary Lynn said, each senior center is unique and offers different services depending on their communities, what their funding capacities are, and those kinds of things. We believe that strategic investments are needed for long overdue capital maintenance, building modernization, and the creation and expansion of existing services and space to meet the needs of the increasing numbers of Wyoming senior citizens. Below, I just highlighted the different programs that our senior centers provide. You all, like what you've said, have been in senior centers. So we have the nutrition program, the congregate living, the congregate meals program. This year we had to shut those services down across the state, but we responded by delivering many more home delivered meals. We also offer health and wellness activities, lifelong learning and socialization, care coordination, outreach and assistance. So connecting the people to resources that they need, the in-home services programs that we offer through the Wyoming Home Services Program. We also provide those services through the Community Choice Waiver. the Medicaid waiver. We have contracts with the Veterans Administration, and also long-term care insurance can also help pay for those services. Many of the senior centers provide public transportation. We receive funding through the Wyoming Department of Transportation, both federal and state. A number of us provide adult day centers. Unfortunately, there are only 4, I believe, that are licensed in the state, and we believe there could be many more opportunities to grow that program. And then another really important program is our family caregiver services, and supporting those people that are taking care of their loved ones at home. So we would like to thank the Wyoming Department of Health and the Aging Division for all of their support, and all of you for your support this past year. And I think that does it. I've got the PowerPoint slides here, just identify what's happening in Sheridan and some of the programs that we're providing there.
So finally, we had in the last sheet, we wanted to bring up that in the late 70s, there was a senior citizen service districts that were created by the legislature. And out of that have about, if I can best gather the information, it looks like numerous counties, as you can see on this list, Converse, Crook, Eastern Fremont, Johnson, Niobrara, Platte, North Bighorn, and South Bighorn do have the opportunity for a mill levy. They've gone through a vote of the electorate. I think this is something we would want to discuss a little more and possibly ask for some consideration after maybe working with the county commissioners. There has been feedback that I've gotten about the difficulty in getting these districts passed. In particular too, that the legislation, I don't know if it mirrors other districts, special districts, but after it's first created, then in 2 years, they have to go back up for an election, then every 4 years after that. And so there was some talk about maybe removing that requirement that after 2 years, when they're just getting started, that they would have to go through another election cycle. And I did put in here in 2013, there was a Senate File 163, which actually was sponsored in part by the president of our Senate, which didn't actually get consideration, but it removed that overall requirement to go back to the electorate and say that the district special senior districts would continue unless there was a petition of about 10% of the electorate, and then they would go back through a vote. So I'm not sure that would be taking it too far. But I think these districts can be county or smaller. And as you can see by my description, and numerous of them are smaller than the entire county. In researching the senior healthcare districts, which was passed in 2020, I know a number of you are familiar with it, having served in the legislature. They're modeled more after a rural healthcare district. In my research, was not able to see that anyone is yet working on developing one because it would need to go through a vote again. But I think this is an option definitely on the table for more sophisticated kind of nursing home or that type of care, less so in terms of the community type care that we are talking about here. But over the next session in September and on, we'd like to visit with you about a handful of policy options. The home services program was evaluated a bit in 2017 with the long-term care study that the Department of Health completed. And out of it, they did come up with a handful of recommendations. And if it was the will of you all in the legislature to try to figure out a way to continue that funding, they did provide a couple of options that I think are worth giving some consideration to. Also, we would like to support the concept of pilot projects. I do know in the northern part of the state right now, there is in the Powell area some look at the federally qualified health center working with the senior center along with the Manor program to potentially get some AARP funding to combine their programs and build a singular building. And we are very supportive of the concept of trying to combine services together in our state because of our low population or extreme distances. We think there can be some advantages gained by putting programs together. So we would support that as well. And as I said, we'd like to visit with you in September about some of the other ideas we have for your consideration. Thank you, Madam Chairman.
Questions for Ms. Schick or Ms. Rideout? Representative Stibar.
Madam Chairman, just a comment. You said nobody's done the senior special districts?
No, so the sheet, there are two senior types of districts. There's the senior citizens district, and there's a handful of counties that have done it. But the new one that was created in 2020 that's modeled after a rural healthcare district. So they would have to go to a vote of the electorate. So we haven't been to that period yet.
Johnson County.
So Johnson did the senior services district. They didn't do the healthcare district. You're exactly right.
They have a healthcare district. They added it on.
Did they? Yes, I know they're
Yes.
the latest county
They're
to
the
do
only
it.
ones that did it. Thank you.
Mhm.
More questions? Representative, or sorry about that, Senator Furphy.
Thank you, Madam Chair. Are there any of these senior centers that are funded through private funding and more self-funded through collection of fees, et cetera?
I know from my experience in Sheridan that we do apply for private funds from donations and donors on a regular basis. About 18% of our budget actually is private donations and foundations. The people that are using our services also all have a opportunity to contribute via suggested contributions, sliding fees, and just fees and fares, depending on the program and the grant that is helping support it.
More questions? I assume you were here, I think you were here when Mr. Laycock was talking about the certified home program in Idaho. I mean, it's not exactly the senior center, but I suppose a person who was in one of those could come out. So do you have any thoughts on that?
We would be very interested in learning more about that. Yes, absolutely.
I think another key component from the previous testimony about the ADRC is that I think coordination of care is a very critical part of services for the seniors. Because as people age, they need an increasing amount of care, and it really is something that tends to happen at the local community. I wasn't specifically involved, but I do recall that there was some questions prior to the elimination of the ADRC program. And Carmen, correct me if I'm wrong, when senior centers were asked, would they prefer that or funding for home services? Is that correct?
Yes, a number of years ago, we were given a choice. So.
And what was your choice? More
to-
home
to
services?
More services at the local level.
Oh, as
was-
far as the.
See, what would tend to happen is that if the state had the responsibility, then they would most likely call the senior center, and the senior center then would continue with the coordination. So I think it's a lot of responsibility on both the state and on the senior centers, that it really, as you all know, getting services needs to happen at the local level, because that's where the services most tend to be. And I might add to this, and I would hope the Department of Health would correct me if I'm wrong, is that in the majority of the states, if not all the states in the United States, they have, in addition to their state aging agency, they have what they call area agencies on aging. And we're the only state in the union that doesn't have that, in part because we don't have these large populations. So my perception is, in doing some research, is that they tend to serve and help coordinating those services, where our only area on aging is our Department of Health. And I would argue that there's increasing needs for senior services, and the Department of Health Aging Division has a great deal of responsibility. I respect everything they do, because they're responsible for licensure, they're responsible for aging things. They're also responsible for a number of the institutions. So I think that really the resources they have are excellent, but we have an increasing need, and they fill that role as the area agency right now. So I think that's a lot that we need to talk about going forward. And the ADRC concept then would be another thing I think that would be added to their responsibilities. And we support that concept, because we do need more and more coordination. But how we deliver those needs and those services will be important in our conversations going forward.
Madam Chair,
Ms. Rideout.
and you might see in the description of our local services in Sheridan, we created kind of our own ADRC with our support center. That's where people come in to get services, where they get care coordination, outreach, and information and referral. So we did it at our local level, and where we see the need. There's a great demand at the local level for us. So I can imagine around the state, it's the same.
Well, and so you're saying, do I understand? I mean, it makes more sense to me that it would be done at the local level, because generally the person is going to want care or assistance from their area, not to move from Torrington to Jackson or Green River to do, I mean, they want it where they're at, right?
Well, definitely at the local level. And I'm not sure all the components of the ADRC and what it all entails. So there might be some part of that.
Exactly. I think
Yeah.
the concept of having a website and having resources available for everyone would be extremely helpful.
Yeah. Yes.
Okay, any more questions? Oh, Representative Fritttner.
Madam Chairman, thank you, Mary Lynn, and thank you both for being here. This is kind of out of your purview, but assisted living facilities, there's a need, obviously. Are you seeing an increase in those facilities being built statewide, privately?
I'm not aware statewide. I know again, in Sheridan, there's just one, and I don't know of any other plans for another.
And the reason I ask is my grandparents were some of the first residents at Sugarland.
Yeah.
And my father-in-law is part of a economic development group in Bighorn County, and they had looked at trying to retrofit the Basin Elementary School and convert it into an assisted living facility, and just couldn't do it because of the asbestos issues. But there really is a need for that. But the hard part is trying to find private investors and people that might be willing to step up and provide the much needed revenue to build those facilities.
I think that speaks to the point that we really need all the continuum of services in the state.
This issue will be on the agenda more again. That will be Ms. Hudspeth again. Representative Romero Martinez.
Thank you, Madam Chair. I noticed that the senior center in Cheyenne is kind of a hodgepodge. It's, first of all, it's age for sure, and in need of update to me would be kind of putting a Band-Aid on it. We just need a brand new facility if we care about our senior people. We just the same way we build new buildings for anything else. But I call it a hodgepodge because you have a variety of disabled people living in a kind of an apartment complex next to it, which then harbors visitors, and it just becomes a mixed milieu of company, and then it doesn't really get to the goal, and if anything, it muddies the water there. And do you see that also in other areas throughout Wyoming?
Well, I think the senior centers vary dramatically throughout the state. Some of them do not have many resources to build new facilities, and others do. So it's really, I think a handful of them have been able to take advantage of some of the CARES dollars. Carmen, you might be one of those folks.
Yes, we were able to get some funds from the State Land and Investment Board for HVAC for our facility. But they are approaching 50 years old, a lot of those organizations and the facilities. So yes, I think the organizations have been making do for that many years.
And sadly, as nonprofits, they don't have capital funds, so they have limited resources. I do know that a handful of the senior centers have discussed with me some basic needs they have and hoping for ARPA funds for things like a new roof, paving their parking lot, things of that nature. So I think they're just really, I think the notion of having fundraising in some of the more wealthy communities, it's helpful, but in some of the little communities, if you drive in through Shoshone, you see they have a nice little senior center, but it's just tiny, and I don't think they probably have a lot of additional resources to build on it. But we'd hope going forward, as the senior centers tend to be the community locations, I think, in the majority of the locations in the state, we can help build on those resources and maybe help develop them into what Carmen said is the concept of maybe kind of like the student center for senior centers, so folks can hopefully spend time there and congregate while they're able to be in their homes.
Mine's working. Do you want mine? Ours?
What'd you do? Magic, that was cool. Okay, I lost track. Representative Kennelly, I believe I saw your hand.
Yes, thank you, Madam Chairman. Do you think some of these APRA funds should be used for the senior citizen centers?
Madam Chairman,
Representative
Representative Halverson, we would be delighted if that opportunity exists, and a handful of them are working on proposals and ideas and looking for the vehicle if that is a possibility going forward.
The other Representative Connolly.
Thank you, Madam Chair. Just a comment as we go down the road of talking about these special districts and additional legislation, and a comment that was just made. It's one of the reasons that I'm always a bit hesitant about special districts. It seems to me that it's the wealthy communities that can and do, and those that really can't tax themselves don't. And it concerns me, honestly. And I hope that you take that into account, and not just that can't just be the solution going forward because of that, or else I'd like to hear more about it.
I agree with you, Representative Conley. I do think that we're trying to come up with as many vehicles, and that those communities that do have those senior districts, for instance, in Crook County, it really is what supports that senior center. So it's just that one option that has been exercised and mentioned in Johnson County. They were getting a little bit of county funding, a little bit of city funding. They were getting these recreational district dollars, and by passing this, they have been able to rely on this and not use those other dollars for their long-term future.
More questions? Representative Fritttner.
Thank you, Madam Chairman. And Marilyn, so you talk about these facilities, say 50 years old. What built those originally 50 years ago? Was it state dollars, county dollars, private?
Ms. Rideout. Looks like you're going to answer.
Madam Chair. Again, I think a lot of it was local communities. So I know in Sheridan, it was optional 1 cent sales tax money way back in 1980 that built the first one, the first piece of that.
So back before people expected the government to save them and solve all their problems, right? Sorry, that was just a little.
Don't you think?
Isn't it just the opposite? I mean, it was, the government did pay for it. It was sales tax.
Representative Connolly, you want to restate that?
I am curious about the comment about the government, because it was a sales tax. Isn't that the government coming in?
But that's paid for by the people who buy things.
All right.
So I have, while we're having these interesting conversations, one thought that strikes me, and I'm wondering if you can, I've been in my senior center one time, but as we think of the aging of Wyoming, the aging, what we see is as the far end, more people get into the old end. It's probably linked with fewer people on the young end. There are some communities in the state where they are closing schools. So as you think of an average elementary school, say, that is perhaps being closed, is there a way in which the facilities in there could be suitable for a senior center? I mean, they typically have a gym, a kitchen, and then a bunch of rooms. Any thoughts on that?
Madam Chair, I know in Newcastle, they did do that with one of their schools. They transformed a school, an old school, into their senior center.
So I'm wondering, I don't know, Mr. Brody, if you know, or anyone on the committee that's involved with education, maybe Representative Connolly, when the school facilities folks in the districts close schools, what is the statutory requirement as far as how to dispose of the school? I mean, if we could put senior centers in some way, not that they would have to come up with $2.5 million to buy the school, but you know what I'm saying? Do you know anything about that, Representative Connolly?
Thank you, Madam Chair. The only thing that I do know is that it gets put, that decommissioned school gets put on the list because it gets put on the list for school facilities money to, for example, take it down. And that often gets put to the top of the list because of hazards that are associated with keeping a decommissioned school around. But I do know of other buildings, for example, that have been turned into something else. So, for example, in Laramie, the old high school is now the Civic Center. And so that was decommissioned as a school, but turned over to the city at some point, but I do not know how that happens.
Katie or Mr. Brody, or somehow could we ask you folks before September to investigate what the process is for disposing of school buildings that are not being closed because they have asbestos or something, but because the demographics have changed in that community. Maybe it might be a source of not so terrible buildings, better than nothing. I don't know. Okay, any more questions for the ladies? I guess not.
Thank you
Nothing
very
else?
much.
Okay, thanks very much. Is there anyone else online? Maybe there's public, oh, I see Ramsey Scott has got his hand up. Look how good I'm getting. We'll turn it into public comments, seeing as that, and actually, I've seen, now we do have time to get the Department of Health back in, but we'll go ahead and break for public comment and circle back to the Department of Health. Hi, Mr. Scott, how are you?
I am well. How's everyone doing?
Introduce yourself for the committee if you would.
Absolutely. Ramsey Scott, I'm the public policy manager with the Alzheimer's Association Wyoming chapter. And, just kind of want to go and reinforce a lot of what has been said by everyone who's been speaking. The aging in Wyoming, the cost for healthcare, those living with Alzheimer's and other dementias has a big part in those high costs and the need for better care. So I figured what I would do, especially because we have a lot of new members, and we also, even though we might have some extra time, I don't want to take too much of it away from y'all. Just give some of the new members a little bit of an overview of what how Alzheimer's affects Wyoming and our caregiving population, and how we really think like some of the ideas by my colleague Tom Laycock over at AARP would really help our specific community as well. Currently in Wyoming, we estimate about 10,000 people living with Alzheimer's or other dementias. We also expect that by 2025, that number is going to increase by 30%. What that means is that there's going to be a higher cost of care. Just to kind of give you an idea of the impact that those living with this disease have on overall budgets. It's estimated that seniors with Alzheimer's, without Alzheimer's or other dementias, cost roughly about $70,750 annually in Medicare spending. When you take into account Alzheimer's, that price goes up to about $25,000 annually. Just how the nature of the disease, unfortunately, it requires extensive care, which is why family caregivers are such a huge component of both not only keeping those living with this disease and other dementias out of long-term care longer, but giving them better care. Roughly, there are about 16,000 people in Wyoming providing unpaid compensated care. That's estimated to be a value about $379 million annually. That means that money is not hitting the state's budgets. A portion of that, if those family caregivers were not providing that care, a good chunk of that could be landing on the state's budget. So they're really not only doing a service to their family, but their community as well. And one thing that we've kind of discovered recently, and kind of going into the piece that Tom talked about on the family caregiving, Wyoming Home Services, those programs that have supports for family caregivers. In 2019, there was roughly about 28,000 unpaid caregivers, and they're providing about 31 hours a week of uncompensated care for $396 million. Then we can't necessarily say why that number has dropped in the past 2 years, but there's less uncompensated care being provided. And so there's more money that's going on the state. And I think it just speaks to how important family caregivers are and the reason why we have to find ways to support them. That's why, we supported funding the Wyoming Home Services. We also support the ideas that Tom and AARP were talking about with finding potential ways to expand those services, whether through the waivers or some other aspect. We definitely think this is a really great place for our funding to go. And another thing that could really help family caregivers is the ADRCs. It's a huge thing. We field calls on a regular basis from people who just have no idea where they need to go to get care for their loved ones. Whether they're in the early stages of the disease or in later stages, they're desperate for someone to help guide them through. We know that the Wyoming Department of Aging is doing yeoman's work and doing so many things, but they just cannot do everything, especially when it comes to hand-holding, getting people through the system. You know, we try our best. We have a 24/7 helpline that's free that we, direct a lot of people to. It helps people trying to find some resources, but having a state located ADRC would do so much in supporting family caregivers. If you're already doing so much, taking care of your loved ones, you're maybe missing work for it. You're spending money out of your own pocket. It's estimated that family caregivers are spending about $11,000 annually out of pocket just to care for their loved ones. They're cutting back about 50% of their day-to-day expenses. They're 1 in 9 aren't buying medications. 1 in 5 are cutting back on their own doctor's visits. They're making so many sacrifices. Going and making 20 different phone calls to try and find a service just makes their lives that much harder. And so we really think if we're able to, which we think we are just from kind of our general understanding of AARP, is to be able to put some money towards that. It would be a huge benefit to not only the Alzheimer's community, but for everyone in the state. Kind of jumping around because there's been a lot of conversations. We know that the potential for rebasing, it might be slim, but you guys are still going to put a bill forward. One thing we would like for it to be considered during the rebasing conversation is taking into account the high cost for providing care for someone with Alzheimer's and other dementias. It is, it could be 2 to 3 times as much as far as cost goes for providing care for someone with Alzheimer's in a long-term care facility. That needs to be compensated because our facilities need to be solvent, and we need to make sure that they are able to afford to provide the care that is needed. And so we would just like for that to be a consideration. Even if it doesn't happen this year, it needs to be part of the conversation moving forward. I'll take one last second to say that, as sitting on the healthcare task force of the governor, working with the aging subcommittee, we really appreciate everything that Jen Davis and Governor Gordon and the entire staff have been doing to try and find ways to provide better care at lower costs. A lot of that is all preventative. And this is where, circling back to the thing I was just talking about, family caregivers, them being supported means less people going to long-term care facilities, which means less cost to the state. It's a good solution for everyone. So I'll quit rambling at this point, stand for any questions, and really appreciate y'all's time.
Okay, questions for Mr. Scott? I don't see any. Thank you very much.
Thank you.
Okay, so is there anyone else online, Katie, for that? Anyone else in the room? We're going to call back on the Department of Health. Department of Health, it seems like not only can we ask you a few questions, but you had a tentative offer of, if I can find my paper here, of talking about aging a little bit. Long-term care overview and refresher. So we've got roughly 25 minutes until we need to leave for, am I correct? For the Lander facility. And so if we can take pretty much that time, I do have, before we, and you've, committee, there's an attachment at the end of this one that says Department of Health updates, long-term care overview. But I put a few asterisks here just to circle back. Okay. And I don't know if you'll touch on this unless otherwise, the discussion from Mr. Laycock about the certified home program from Idaho and the possibility of using AARP dollars to fund a pilot program to reimburse caregivers for family caregiver home care. Do you have any thoughts on that?
Madam Chairman, members of the committee, again, Stephen Johansson with the Department of Health. I'm not personally familiar with the program in Idaho, but we could certainly have those conversations with AARP. I know we have been in discussions with them and have been following for some time the model that Mr. Laycock mentioned with Vermont's, I believe it's a Section 1115 Medicaid waiver, and something as a reminder to the committee that we we presented years ago, a different committee looked a little bit different, but we presented long-term care policy options that did include looking at tiering our long-term care waiver. That is not an immediate solution. That is something that at minimum would take 18 to 24 months, given the work that would have to be undertaken with CMS, with the federal government. But it is something that if directed to go in that, to go in that direction, we would be more than willing to have those conversations. Ultimately, that will come down to, both policy and budget decisions that we could present back to this committee. So that wanted to make that clear, but we'll certainly investigate the Idaho program as well.
I think we'll just touch base with you on that for the, we have a number of things that we will touch base with you on through the summer. Okay, long-term care overview. Mr. Fuchs, it looks like you're on.
Madam Chairman, members of the committee, my name is Franz Fuchs. Good afternoon. Just again, this is kind of a refresher. We did this brief a few years ago, and it's just sort of an overview of what we see as kind of the demographic trends that sort of drive the kind of problem that we see today. And so on our agenda, you can see, if you guys wouldn't mind, next slide, yeah. We really just sort of cover, really this underlying demographic. You've heard the term silver tsunami. It's much more slow moving than a tsunami would indicate. It's just more of a very long-term sort of tidal wave that happens, but tsunami sort of implies a sort of a immediate trauma. And then we sort of get into sort of the long-term care needs relating to the cost, preparedness for retirement or lack of preparedness, not to bury the lead there, and the issues with the long-term care insurance market on the private side, before we finally get into sort of the public payers who ends up sort of holding the bag when it comes to paying for long-term care. So really the summary slide kind of is the nutshell. We are the largest payer for long-term care services. And the state of Wyoming will see increased costs from an aging population, mostly through its Medicaid program. And you can see the costs for Medicaid. We're looking at increase. We're currently spending about $145 million per year. We're projecting that to increase to over the next 10 years to between $184 and $312 million. And that partially, some of that's determined by the demographic factors, but some of it can be bent somewhat by the policies that we pursue as a state. There are 5 major factors that really drive this issue. One is the aging population, which we can't do anything about. This is really just demographics. This population is increasingly burdened with chronic diseases. And that sort of leads to this decreasing ratio of working age adults. So not only do you have fewer taxpayers per individual or older person, but you also have decreasing numbers of unpaid caregivers, as Tom alluded to, and Ramsey alluded to. A lot of this work is unpaid and uncompensated. So that decreasing ratio is just sort of problematic in kind of two ways. Long-term care of court costs are increasing, and this population is really increasingly unprepared to pay for those long-term care costs out of pocket. They are astronomical when you consider the average family budget and assets. When you look at the private sector, there are of course products out there in the market, long-term care insurance products. But the problem is that insurance market is relatively small and it's weakening, and so there's really significant problems there. With respect to people purchasing long-term care insurance products. So at the end of the day, our recommendation is that the state continue to develop these policies that encourage healthy aging at home. And you've heard this message over and over again from not only us, but AARP and other folks in this room. And just for the 2 simple reasons we kind of alluded to in the Medicaid 101 is as you heard, most people would prefer to remain at home. So it's preferable for those individuals, and it's cheaper to the state. And so you can see updated per member per month costs there for nursing facility and our home-based community choices waiver. Moving on to demographic projections. This is just a kind of a slide to show over time, from we're about 2020 right now, right? Sort of in the middle of this graph out to 2030. We kind of split them into 4 major age groups. Kids 0 to 19, working age adults 20 to 64, and then your younger elderly and your older elderly 65 to 79 and over 80. And you can kind of see how those numbers change as a ratio of the total population. Is the next slide, slide 9. And you can see that we're basically increasing. So back when we did this presentation back in 2017, it was Around 3.5% of the population will be over 80 and 15.5% over 65. That's, you can see increasing to about that sort of, again, slow motion wave, right? Sort of cresting around the mid 2020s to about 20% over 65 and 5% over 80. And then the ratio of the working age adults to those who are over 80 decreasing from 16.8 to about 10.1 until 2030. So that's really the fundamental kind of demographic problem that we're facing. As far as long-term care goes, of the Americans turning 65 today, and this study was maybe a little older. I know you think you heard a different number from AARP. It's roughly a coin flip according to this study of whether or not you'd need long-term care. And you can see kind of the distribution of how many years of long-term care. So the average, was, I think 3 you heard, but you can see it's a little bit skewed, kind of to the left. So you have a large number of people requiring less time, but then you kind of have a tail going out to the far, over 5 years. And on average, so for if you are in that 50% that require services, you can expect the average expected cost is $266,000, or it was $206,000 in 2015 dollars. So that's obviously much higher, or higher today due to inflation. We did update the Genworth estimates here. So this is 2020 cost of care survey. You can see the costs for Wyoming for 3 types of care: home health, assisted living, and nursing home. Those are the 3 columns. And then how Wyoming compares to other states. So we're fairly average when it comes to the, compared to the US median. A little bit higher on the home health side, but you can see roughly average on the assisted living and nursing home, which would be the dominant sort of modes of long-term care. But it is colossally expensive for the average person. Ultimately, people are really unprepared to pay for this cost. There's multiple ways that long-term care can be financed. And people can draw down their savings accounts. Either, if they're lucky, they have income that can pay for it. If they're not, they're drawing down their principal. If they're less lucky, which is most everyone else, they'll go into Medicaid ultimately. There's also defined benefit plans that are decreasing, and generally speaking in this country. Most pension plans now, retirement plans are defined contribution as an increasing share. And then long-term care insurance is an option for some people. That's, again, we'll kind of get to why can be a problem. There's sort of a paradox with long-term care. I think the saying is if you need long-term care, you can't afford it. Or sorry, if you need long-term care insurance, you can't afford it. But if you can afford long-term care insurance, you won't need it, because you can pretty much self-insure for long-term care. You'll have enough assets to be able to just pay for long-term care yourself. So that's kind of the paradox, the real fundamental problem with long-term care insurance as a product. And then a lot of people do have home equity. But generally speaking, on slide 14, you can see households nearing retirement age between 55 and 64, almost half, 41% have zero retirement savings, none. And then the overall median net worth for those who have savings is around $104,000. So that can be wiped out in 1 year of nursing home, right? So ultimately, kind of saving is really not really a viable strategy for most people when it comes to long-term care, for the average American in any case. You look at defined benefit plans. Here's just slide 15, kind of showing the growth of defined contribution. Really, the growth in retirement plans has been entirely in that area. Defined benefit plans are kind of almost a relic, and we'll probably continue this trend of decreasing. And then finally, slide 16, you can see the outlook for long-term care insurance. These are just a couple indicators of why the market is kind of not very healthy, I guess the way to put it. This is coming from a 2016 study, so the data could be, it's a little bit old. You can see the number of covered lives is pretty stagnated. It has stagnated since the early 2000s. Number of individual market sales has also started decreasing since a peak in 2000. And then on the next slide, you can see the poor actuarials for this sector. The actual claims to expected ratio is over 100, and the annual loss ratio has really been increasing significantly. So I think the National Association of Insurance Commissioners blames poor actuarial projections on the morbidity and mortality of this population as being the primary reason for this performance here. But nevertheless, long-term care insurance as a product is it's just not a good outlook, generally speaking. And there are other financial products out there. There's life insurance that have hybrid kind of options that people can choose from. So there's all kinds of different vehicles that people can choose from on the private side. But generally speaking, the state will ultimately be left holding the bag for a lot of long-term care. That's, I think, the point I want to make. So slide 19, we provide long-term care through two major programs. We have skilled nursing facilities, or SNFs, nursing homes. And then we also have the community choices waiver, which was formed with the merger of the long-term care and the assisted living facility waiver in 2017. We have some just tables on 20 and 21 on the just facts of expenditures, member months, enrollment, and PMPM. I don't have to read that to you. It's just for your reference. But I think the bottom line figure is you look at the last PMPM, right? 2020 for community choices is about 1,700. And for nursing facility, it's about 4,800. So the cost to the state for community choices is significantly cheaper than nursing home. That's not to say that everybody who gets on the community choices waiver would have 100% gone to a nursing home. And that's really when we get to the issue of does it definitively save the state money? We can't necessarily prove that 100% because a lot of people on the waiver may have been nursing home eligible and but they may have had a family member who would have taken care of them or something, or they may not have wanted to go to a nursing home. So there could be multiple reasons why people are on the waiver and they would not for sure have gone to a nursing home had the waiver not been available. So it's just a tough kind of hard to know exactly, but certainly on a per person per month basis, it's certainly significantly cheaper to the state. We did some scenarios back in 2017 on the long-term care costs for Medicaid. We're tracking pretty closely. It's still only, we're only at 2020 right now. We're about 145 million currently. So we're kind of on between scenario B and scenario C. So we are on, I think, a good track as far as overall costs. We're not on the worst case scenario. And that's largely due to our a lot of, most or almost entirely all of the growth in the long-term care population of Medicaid has been on the waivers. So nursing home census and enrollment is actually lower than it has been. I think almost in 2010, 2015, somewhere in there. It's actually one of the lowest points in recent memory. That's kind of all we had for that refresher. We did have a couple slides on occupancy trends. We saw there the availability of beds was a topic on this agenda. So we just wanted to pull some data. There's a really great data source that CMS requires nursing homes to submit what's called payroll-based journaling data. So it's literally daily data. They have daily data on the census, on the number of people working that day and so on. And so what you see on this graph is each little gray line is an occupancy statistic. So a trend in occupancy for a single nursing home in the state. And you can see how they go up and down. I put a dark line there for when COVID, the epidemic kind of started. But you can see the occupancy really didn't start dropping significantly until the real big COVID wave hit in October, November. And you can see the red line on this graph is the average of the nursing homes that reported sort of data. So the red is sort of the average and all the gray lines are individual nursing homes. And so you can see the occupancy has decreased from around, between 75 and 80% to almost 65% today. So it's a pretty significant drop in occupancy.
So Franz, I have a question on that, and you may just have to hypothesize unless someone in the room wants to add to that. So, a few thoughts come to my mind about why that is. One, the occupancy might be down because the residents passed away from COVID. Or another possibility is that when people saw the lockdowns occurring, they decided to stay home and not go into a nursing home where they would be locked down. In which case it would probably rebound with a higher acuity, or, in the second possibility. In the first possibility, I suppose it would just flatten out. Do you have any thoughts on that? Or, and some people in the room may have some thoughts.
Madam Chairman, I think your explanation it's probably very reasonable. A nursing home has a flow of clients in and a flow of clients out, and COVID probably increased the flow of clients out due to death, due to COVID, and then also stop more new people from coming in for those reasons you mentioned. The restrictions and the difficulty of getting visitors, that kind of thing, probably made nursing home significantly less appealing to a lot of people. So if I had to guess, those seem like very reasonable hypotheses. I don't think I know for sure, but I'm certain some industry folks here may have an opinion.
Go ahead, Don.
And then the final slide is really just talking about staffing trends. It was interesting to look at the journaling data. You can see, so average staff hours per resident per day. And then the dark gray are CNAs, the light blue are LPNs or licensed practical nurses, RNs are the bottom, the dark blue. You can see individually on the left and then stacked on top of each other on the right. So I just thought it was interesting that the trends remain relatively flat, except for when you saw that significantly decrease in occupancy. We had a little bit of a bump in the staffing per client ratio, but it looks like the nursing homes kind of adjust to their workforce to some degree to their census. And then you can see the effects of weekends. You can the little vibration is when they have fewer staff on the weekends. Fun fact. So the data is pretty granular.
Questions for Mr. Fuchs? Representative Connolly.
Thank you, Madam Chair. Mr. Fuchs, I want to go back to the slides or the discussion about the what is it called? Long-term care coverage.
Representative Connolly, if you can move the mic just a little closer to yourself.
I want to talk about the long-term care coverage and in particular about the state of Wyoming. My day job is as a UW professor and I'm under state benefits. Last month, I got a notice that the long-term care coverage under Jen Worth, which was an employee paid voluntary benefit, was no longer available. Do you have any idea why the state would choose to not allow employees to participate in that kind of program when it seems to me that if you had it, it would certainly have helped with some of the costs down the road?
Madam Chairman, Representative Connolly, I can't speak to if it's EGI that operates that, the state employee insurance plan that operates. I certainly can't speak to their policies, but I would guess, I don't believe EGI, and I'm going out on a bit of a limb here. I don't believe EGI operates its own long-term care insurance plan. It's probably just a partnership with Genworth to offer those plans for sale, basically to state employees. I'm sure those employees could probably buy them independently. I don't know how much money the state kicks in or not, but that would probably be a good question for EGI. I'm afraid I'm probably not qualified to answer that.
Any more questions for Mr. Fuchs? Senator Furphy.
Thank you, Madam Chair. This may be a silly question, but I don't understand it. What about not Medicaid, but if you're covered under Medicare, does it cover any of long-term care? Thank you.
Mr. Fuchs.
Madam Chairman, Senator Furphy, Medicare covers a limited amount of long-term care. I think the benefit is around 100 days of nursing home, and it has to be after a hospital, being discharged from a hospital. So it's a very limited period of time, and the focus is basically rehabilitative. So the focus is really on getting physical therapy, occupational therapy, respiratory therapy. It's not necessarily the longer term kind of custodial long-term care that Medicaid really pays for. So that limit is pretty hard limit, and a lot of people find out, unfortunately, that Medicare doesn't really cover long-term care in the long term.
Okay, any more questions for Mr. Fuchs? Representative Romero Martinez.
Thanks for putting that presentation together. It seems like it's pretty clear that we're having a breakdown in the family. So by the time grandparents need the care, where are the grandchildren and the children at? I mean, do we know? Do we have statistics on that? I'm pretty sure we probably do, but we're just, if you could respond.
Mr. Fuchs.
Madam Chairman, Representative Romero Martinez, I think family caregiving has happened since time was time, forever. It still happens. There's still a lot of, I guess now it's being just considered more like uncompensated care in a way. We did that sort of history presentation on the Medicaid 101 last joint labor. Before there were nursing homes, there were, rest homes back in the 50s, which were boarding houses in the 30s, which were, the poorhouses of the 1800s. These institutions have been around, forever as well. And so there's always been family members who couldn't take care of their family. So I don't think these problems are new. I'm not sure it's getting worse or better or worse. I'm not sure the trend there, but I think both these problems have very, very deep roots.
And I'll just add to that, Representative Romero Martinez, that if you consider the changes in, two parents working, if both people are at work during the day, that makes it a little difficult to have someone at home taking care of wandering mom or wandering dad. Families have tended to move farther apart. And the other thing is that people are living longer. I mean, it's a lot easier if you only have to take care of grandpa until he's 67 and then he has a heart attack. When he's 87, that's 20 more years worth of caregiving. That is, I mean, there's a lot of factors to that. Did you have a follow-up?
I guess I just wanted to make a follow-up comment that, I mean, I'm sure we all know it's connected. Speaking of, and thank you for those comments too, Madam Chair, is another component is dignity and pay. I mean, if two people have to work because they're not getting paid, right? It's not because people aren't working, it's because they're overworking for lower pay. And since this is labor health, at some point, I would hope maybe we can come up with some solutions there. And I don't want to say any more than that.
Thank you.
Madam Chairman.
Representative Ottman.
Yes, thank you, Madam Chairman. Did I hear earlier today that there is compensated care now? There was something about $1,500. Did that go to family caregivers or something, or did I hear that? Because that was an issue a couple of years ago with a family. I knew that if she could have had some sort of a reimbursement, that would have made it a lot easier. But I thought I heard that somewhere today and I thought it was new.
Representative Ottman, that was a presentation from Mr. Laycock from AARP about a pilot program in Idaho. And that is where I have asked if we can get further information for our September meeting.
Okay, thank you. I heard part of it. Thank you.
You heard all the words.
And Madam Chairman, if I may, Representative Ottman, to that point, we do have a family caregiver support program. It's been mentioned a couple of times today. In the grand scheme of things, it's a relatively small program in our aging division, but one that, in addition to some of the policy options we've discussed with this committee over years and years, one of those is, should the state invest more heavily through the aging division in the caregiver support program for this type of uncompensated care.
Representative Ottman.
Madam Chairman, what does that small program look like?
Madam Chairman, Representative Ottman, happy to get you a breakdown of that. We have financial and performance data on it, which we can follow up with you on.
Okay, any last questions for Mr. Fuchs? Okay, then we've got 3 minutes. Wow, we're so ahead. And unless there's anyone hanging around for public comment. Okay, then public comment will be closed and we will recess until.
Madam Chairman, just.
If I can, does that need to be stated before I finish my sentence?
Just a quick question with regard to the nursing home administrators. This was included before we recessed. I wondered if we needed to address that.
Mr. Boley is going to present on it tomorrow.
Okay, all right, thank you.
So remember, if you're going to go on the tour of the Life Resource Center, we need to have masks. People can feel free to carpool if they want to, but obviously if you're going to detour to various, then you'd have to bring the person back here to pick up their car. So you might not want to. Just put in your smartphone about how to get there. It's not hard. And remember the offer to join the college folks for the ceremony at the flagpole tomorrow. If you'll be there at like 5 until 8, if you want to participate in that. And Chairman Baldwin, is there anything else that we need to remind people about tonight? Okay, then we'll recess until tomorrow morning, 5 till 8 at the flagpole or 5 after 8 inside. And we'll see you at the Lander facility.
Is this room going to be locked, Madam Chairman? Is this room going to be locked? At least very good.
And actually, committee, if you are not going to go to the Lander facility, would you please let me know so that we don't stand around the parking lot waiting for you to show up before we start touring?